Thank you. I'm happy to be here. I just want to start by saying Bridgen could not be here, as Rena said, and we miss him, but he's here in spirit and helped us with our presentation, so his words are our words in this presentation. We have nothing to disclose. I will disclose I'm on cough medication right now, so bear with me. I want to start off with a quick poll. I know not all of us are physicians. We have a mixed audience. But for those of you who are physicians, I want to get a sense of how many of you have been trained in patient safety, just with raise of hands. Okay, that is 1.5 maybe? Okay. Okay, well, maybe a formal curriculum, a formal or exposure. So we'll get into that. And for those of you that were trained in patient safety, were you trained as a practicing physician, as a resident or a fellow? Definitely as a resident, okay. So no one is a student then, I'm gathering. Well, I will say that this is definitely making the case for why we should have patient safety and quality improvement training within the MD program. And I'm going to start with a quote that says, "Everyone in healthcare must recognize they have two jobs when they come to work each day, doing the work and improving it." And this is to say that while we can teach the science and clinical skills around patient care, we can't really move healthcare forward without teaching everyone who is a healthcare provider how to make effective changes and improve patient care. And I'll start with the seminal report that many of the physicians in the room have heard of, and this is the Institute of Medicine's "To Err is Human." And in this report, we really learn the extent to which medical errors occur, and we can look at the statistics up here, and they're pretty horrifying. And this report really makes the case that there needs to be a comprehensive effort towards reducing medical errors, and they state that education is one of those elements. There are other factors that are really influencing the need for patient safety and quality improvement curriculum. One is our regulatory bodies. The Liaison Committee on Medical Education uses the lens of patient safety to ensure that medical students are adequately prepared and supervised when taking care of patients. And in our licensing bodies, medical students and residents are assessed on quality improvement and safety science. And of course, residents need to have the necessary skills and experiences before leaving residency. And we believe here at Mount Sinai that having a curriculum as a medical student will really give you the foundational skills to be successful in residency. And these are just some, these are just some examples of the different specialties and the types of skills and experiences that residents are exposed to. So we've talked a bit about the external needs of why there needs to be patient safety and quality improvement in medical education, but we also have our internal drivers. And one of those is our need as a medical school to be to have an innovative curriculum and really produce the best possible physicians from our medical school. And that is threaded throughout our school mission and, of course, by default, our curriculum. We also are part of a massive health system which has major initiatives that are focusing on patient safety and quality improvement. And most physicians and healthcare providers are participating in some sort of aspect of that. So I'm going to talk to you about how we developed our patient safety and quality improvement curriculum and how we implemented it. So the first thing you need to know and understand is what InFOCUS weeks are. You heard that Rainier and I are the co-directors of InFOCUS 5, 6, and 7, and what is that really? So in 2012 and 13, the Curriculum Design Committee really evaluated our curriculum and looked at ways in which we could revamp our curriculum to be very innovative and forward-thinking, and really prepare our medical students to be the best possible physicians. And one of the ways that we felt that they could get some of their information outside of their regular courses is through what we call InFOCUS weeks. And we focus on various themes throughout each week, and they're really primed to be relevant for what that student is, what the students are experiencing at that time, and to ready them for their professional development. So this is what all 4 years of InFOCUS look like. In the first 2 years, you can see that there are 2 weeks per year of InFOCUS. And I'm not going to go into detail about those weeks because that's a whole nother grand round. But I do want to focus on year 3, which you will see has 3 weeks. And if we drill down into year 3, you will see that InFOCUS 5, 6, and 7 break up the year and are generally breaking up each module period, which is when the students are having their clerkship experiences. And when we were designing this course, we were really looking at the 3 weeks as one comprehensive course. So it is not a standalone week, and you will hear as I talk about the curriculum a bit more how we tried to build upon the skills that they learned in InFOCUS 5, in InFOCUS 6, and so forth. Before I go through the themes, I really want to introduce our team. This curriculum team is key to the success of InFOCUS 6 and 7. You've already seen me and Dr. Soriano. I want to highlight our student affairs team who focuses on the career planning services and wellness component of InFOCUS 6 and 7. I want to highlight Dr. Hoysack and Dr. Trulio who do the advanced clinical skills for us. And then Dr. Shaw and Dr. Chang who do the patient safety and QI. And finally, our amazing administrative staff who really help the logistics happen. This is a very complicated course. It's extremely experiential, and there's a lot of moving parts. And we started off with Megan Sacco as our InFOCUS coordinator, and she really laid the groundwork and has set it up for success for Jennifer Galindo, our new InFOCUS coordinator. And then we also have Jennifer Reyes and Tammy. Tammy oversees our clinical curriculum and is very focused on years 3 and 4 and critical to the success of this. We could not do InFOCUS 5, 6, 7 without a whole host of educators. And probably within each week of InFOCUS, we have over 65 other educators. They span across the health system, and we tried to make it as interprofessional as possible. As you can see from this list, we have fellows, nurses, nutritionists, residents, a whole host of people, and we really rely on them to bring their expertise to our experience. So when the core curriculum team first met, this is what, 2 years ago? It feels longer, but 2 years ago, we really did quite a bit of research. We looked at best practices in journals. We looked at national standards. We looked at student outcomes, and we also recognized the need to make sure that students met all their milestones throughout their 4 years. And as many of you know, year 3 has many milestones that students have to make in order to advance in their career. And we came up with a list of 9 overarching goals. And I'm not going to read through each of them in the interest of time because I want us to get to the patient safety and QI portion. But I will say that they fall into 5 themes. One theme is learning on the wards, one is clinical skills, one is patient safety and QI, and the other is professional identity and wellness, and then we have career planning services. So as I mentioned to you in the beginning, we looked at this course as a comprehensive course. So what students learn in InFOCUS 5 gives them the foundational knowledge for what they need for InFOCUS 6 and so forth. And it really it's intended to be very timely and relevant to what they're experiencing while they're going through their clerkships. So while they're learning on the wards theme focuses, for example, on how a student might be assessed in their third year. During InFOCUS 6, that we're then looking at how they're reflecting back on their clinical experiences and how might they use the feedback that they learned in InFOCUS during their prior clinical experience to advance them forward. And therefore, also making additional personal improvements in InFOCUS 7. Another example, clinical skills. During InFOCUS 5, before they go on to their clerkships, they are learning their basic clinical skills, such as suturing and wound care, things that they are most likely to be involved in, and to give them the confidence to really to feel good once they go onto the wards. In InFOCUS 6, they've experienced a lot of clinical skills. They might have been able to practice some. They've seen a lot of experiences. So we're building their skills and advancing them forward as they go through all 3 weeks. The important thing about the clinical skills component is that we do wrap in patient safety and QI information into that, and you'll learn more about that in a bit. Patient safety and QI, during InFOCUS 5, they're really learning what is the lens of patient safety. How might they, as a clinical clerk, report an issue that they've seen? So very basic skills. And as they advance through, they increase their skills, and Dr. Chang will talk about that a little bit more. Professional development and wellness, really focusing on their resilience as a medical student. As they get more familiar with their role, or when they're in InFOCUS 5, what is the anticipatory aspect of going onto the wards? What are they most fearful about? And then as they move through the 3 weeks, what types of experience, how do they reflect on those experiences and build their own professional development identification? And then we have career planning services. In InFOCUS 5, very basic. Understanding your role, what does it mean to be a clerk, how do you be part of a team? And then as we move through year 3, of course, the residency application process starts to kick in. We have milestones that we need to help students make. There's information that we want them to receive so that they can start making decisions about their future. So we build upon that as we go through the 3 weeks. Our general philosophy, we wanted this to be incredibly interactive and engaging. And therefore, it makes it a very complicated course. Because we have experts coming in to talk about content areas, we generally created those as a large group, and then would have follow-up small groups to engage in discussion. We did a lot of experiential learning, which you'll hear more about, as well as self-directed learning. So I mentioned lectures and large group presentations, small group learning, demonstrations. Excuse me. They go through simulations. So a lot of interactive sessions and varied ways of learning the material. We also engaged with a variety of educators, including peers. This is generally what the week looks like: patient safety and quality improvement in the morning with our clinical skills in the afternoon. And I'm going to turn it over to Dr. Chang.
Okay, so I'm going to talk about the patient safety and quality improvement core and what we did with that. So this is a quote that I think sums up a lot of what we're trying to teach, which is basically that quality improvement is more of the good stuff and patient safety is less of the bad stuff. So we open with that quote. We use that several times during the course just to sort of summarize what it is. Because I think one of the hardest things when I first started learning patient safety and quality improvement is sometimes I couldn't connect the two. Why are they different? And I think patient safety is more like trying to get rid of the bad stuff, and quality improvement is how do we get that bad stuff to be good. So that's the way I kind of look at it. So the goals for us the 3 goals were to learn about patient safety concepts, develop an understanding of system safety, explore how QI was measured and tools for improvement, appreciate the human systems and elements in patient safety, and build a foundation for QI and patient safety skills. I think that this is how we wrote it, but I think the essence of it is that we were trying to get across to the students that while they learn medicine, while they learn surgery, that there are other things that they need to think about. And there are things that they will see there on the wards, and they sort of have an idea of what they should do about it if they saw it, and how they can be part of the improvement process. So that was sort of the overarching goal. And so one of the things that we felt was really important for them to really understand patient safety and quality improvement was that there had to be a huge component of experiential learning. And one of the things that we really wanted them to get out of it is that you are not going to improve the system by yourself, that you would have to do this as a team. And so what we did was we broke the class up into these basically 12 what we called CPI teams, which are clinical process improvement teams. The teams had about 10 to 12 students per team, and they all had a preceptor who was a leader in the institution as far as quality and patient safety. So we have Beth Raucher, who's the director of quality for medicine, leading one of the teams. We have unit medical directors leading the teams. We have Amanda Ree, who does a lot of the pre-op services, quality improvement. She's leading one of the teams. So we had all these people come in who actually do this stuff on an everyday basis to try to help them do that. And so they learned through this, through didactics, through knowledge, and then most of it was experiential learning, letting them get out there and kind of do it themselves, which was a huge component of what we tried to do. We tried to keep the preceptors the same, and we'll get into how that can be challenging just with everyone's schedule. And the other thing we did was we really tried to engage the leadership. So Mark Knapp is here, who was an enormous part of getting all the leaders and people involved in this. And that, I think, really showed the students, hey, this is real. This is not just something I'm saying. This is something that the institution and everybody finds really, really important. So this is kind of how we broke it down. We saw patient safety and quality improvement in three sort of areas. Didactic topics, which is just things that they have to know. There's skills that they need to be able to do with it in order to do quality improvement, and then there's experiential learning. And so what we tried to do is, through 5, 6, and 7, we slowly started to build things away from didactics and skills into experiential learning. So in InFOCUS 5, we had a bunch of people kind of come in and talk about the patient safety of error. So Brian Radbill, who's the CMO at St. Luke's now, comes and talks about sort of the patient side of it. What happens to you when you have an error, and how does the patient feel about it, and how does the doctor feel about it, and how does that interplay? All right. Then Mark comes in and talks about sort of the basics of patient safety. How does it happen? Human and system errors. Those are the things that lead to some sort of error. And then what we really try to get across in 5 is what happens when that error occurs. So what happens when that error occurs, who reports it, and then what does the institution do about that, so that they understand that when they see it, this is what's happening to that particular scenario. And so one of the things is reporting errors. So the system we use here at this hospital is MERS. So we teach them how to actually enter a MERS, which sounds really simple. You just like state what happened, but actually when you fill out the form, it's not that simple, and how you fill it out is very different than how we learn how to write HPIs and things like that. So that was an important component. And then we started to give them skills. So how do you create a process map? How do you find out when that error happens? How do you create a process map so you understand what happened? Filling out MERS, and then a fishbone diagram is basically how you take that process mapping to decide what actually happened and what can we fix. And then the team contract. So one thing that we built into this was also this idea of working in teams. And so we had the teams actually create a contract of what they would accomplish, how they would accomplish it, so they also learn how to work in teams. So built into all of this were some skills as well, but they didn't really do any experiential learning at this point. This was just developing the skills. And part of the reason for that is that none of them at this point had been on the clinical ward. They actually had never seen a patient on a team and done all of that together. So they just needed to have the skills so that when they went out there, they could see how those could be applied. So that was InFOCUS 5. And so actually what we had them do is we took a case, a real case that happened, and sort of changed it, and they actually looked at it and created a process map. And this is actually one of the process maps that the groups created, which were actually pretty good. I mean, when we looked at a lot of them, they look like what other people would write. And so it was really nice to see that, and all the groups turned one in. So that was one part, and we'll see how this evolves. So then in 6, we start pushing forward. Right now they've got 3 months on the wards. What can they do with that? So we still continue to build on their skills. So we teach them about high value care. We teach about how cognitive errors, our own thinking, as part of how an error happens. And we continue to build on this, creating a process map and diagnosing cognitive errors. So this is where we really push into experiential learning. So in this InFOCUS 6, we actually have a real process that the preceptors in their groups wanted to process map, and we have them go out there and actually create a process map from a real system thing. Okay? So that was a huge part of experiential learning, and this was actually the part that was the most nerve-wracking for us, because we basically gave them a project and we gave them some details and we said go. We gave them afternoons off to just do it. And I think the first year we were a little nervous about how this would all turn out, but it actually turned out pretty well. And this is one of the process maps. This is an example of one of the process maps they created, which were very nicely drawn. You can see that it sort of how it evolved from that little thing they wrote on the board to something that actually looks really nice and very professional. And I will tell you that some of the groups actually used the process maps the student used to actually put it to their quality improvement teams and actually invoke change. So it's pretty amazing to kind of see what they could do. So that was 6. And then we got to 7, and we really moved away from the skills and really made it all experiential learning. Most of what they did was experiential learning. So they took those process maps and then they actually analyzed them as a team and tried to figure out what could they do to help improve it. And they looked at 2 basic areas. What were areas of patient safety that could be improved? And then they learned a little bit about waste. And so there's waste in the systems that we have, and how could they prevent that? And so this was all experiential learning and InFOCUS 7. And so what they did as sort of like a capstone project at the very end is they actually presented their work, presented their process map and their ideas for improvement in something we called Shark Tank, where we had judges in 2 separate rooms judging the presentations, and they picked a winner. And so these are the winners from last year. There were prizes. Some of them got sweaters. One year we had, what did we have, like a iPod charger. So it's kind of fun, just some healthy competition, some sort of healthy, like, yes, this is like something that they did well. So this was really fun, and I think this really sort of capped it off for us. I think one of the things that I found really, really amazing is that we do have amazing students, and sometimes we just got to let them go, and they do amazing things on their own. And sometimes like that sort of fear was mostly us, not really them. I don't think they feared it at all. I think they felt pretty comfortable doing all these things. So it was amazing to see what they did. So this is just kind of a summary, and you can kind of see how things move from didactics to really experiential learning in 7. And so I would like to kind of summarize 5, 6, and 7 as 5 is kind of discovery. So for me, discovery is like Luke Skywalker finding the Force, right? Like they know it exists, right? So now the 5 we're like, hey, it exists, it's there, and you can actually be part of it, right? 6 is about learning the skills. So I always think about Luke Skywalker, right? Sort of learning the skills. And I always think that 6 was always hard, I think, for us, and I think sometimes for the students, because sometimes it was hard to know where it was all going. And actually, that's how I felt when I watched Empire Strikes Back 2. I wasn't really sure where it was going, but it's really the development of skills, right? And then 7 is really making a difference, right? Now you can take all those skills and actually make a difference. Take a real process map and come up with solutions. And so I always think about that as Return of the Jedi, right? That's where Luke Skywalker actually makes a difference, right? He uses those skills and he defeats Darth Vader, right? So I think that's kind of how I see the patient safety and quality improvement in really simple terms. It's just like, it's discovery, skills, and then trying to feel like you're actually going to make a difference.
So since this is a new course, it's always important to look at the course evaluations, and the same process. We ask the medical students to look at the process and do continuous improvement. We did exactly the same thing for our evaluations for InFOCUS 5, 6, and 7. Look at it and continuously improve the courses. So this is looking at 2 years worth of data. So let me orient you. So the blue is InFOCUS 5, red is InFOCUS 6, green is InFOCUS 7. And the left side gives you the course quality in 2016, which is the initial implementation of the course, and then 2017 is the second iteration of it. So in the same way that we're trying to do it for the CPI groups for patient safety and quality improvement, we try as much as possible to improve the component. And the core components you may remember of InFOCUS 5 and 6, 7 is PSQI. So there's a lot of focus on improving, especially in InFOCUS 6 and InFOCUS 7, given the first evaluations that we received from 2016. I think because people were it's still up in the air. It's a very new course. It's a very new topic. We were also with great trepidation trying to go into this new field of teaching them PSQI. And with seasoned teachers and seasoned and maturing of the topics, we thought that the improvement in 2017 was brought about by these two reasons. If you break them down further into the large, themes or core themes of InFOCUS 5, 6, and 7, we have patient safety and QI, we have clinical skills, career planning, and learning in the wards. The way that the team looked at this is there's always this issue of what do I need now as a third-year medical student at this particular point. And if you look at clinical skills, it's always rated very high in InFOCUS 5, and InFOCUS 6, and InFOCUS 7, 3.7, 3.92, 3.8, and 5-point Likert scale. And if you look at patient safety and quality improvement, there is a gradual improvement of it during 6 and 7, I think because of the experiential nature of the topic coming from didactic topics pushing them into implementation. And if you look at career planning, there's so much improvement in the score of career planning because now they're almost finished with the third year focusing on residency planning, and the majority of InFOCUS 7, in addition to presenting their capstone project, which is the Shark Tank presentation, they also focus on making sure that they actually are ready and all their ducks are in a row for residency planning. So there's always this need from the medical students and how they perceive the course. So the instructional methodologies, again, we have more seasoned teachers. We have more of a better handle of the materials in the course. So we thought from our perspective that we actually chose the right amount and variety of instructional methods for InFOCUS 5, 6, and 7 with a heavy dose of experiential learning. The teachers that we do have, like Shashi just mentioned, some of them are quality officers, some of them are real PSQI experts, but some are educators with some experience in patient safety and quality improvement. The first iteration of the course is a little bit lower than the second, and I think, again, with seasoned instructors, I think with a better handle of the information as well as the content, we're able to deliver it to the medical students a little bit better. In terms of knowledge, and this is just a multiple choice question exam focusing on definitions of patient safety and QI and the application of it, as well as high value concepts, which are in the green. And this is after all 3 weeks of InFOCUS 5, 6, and 7. This is percent correct that they get from the knowledge quiz. You can see if 84, 90%, 91% that they do understand and grasp the concepts, the definitions, as well as the application of the process. We did not do a pretest on the students. First of all, we don't want them to get frustrated because they barely have any idea about patient safety and QI. So we thought it was a good way to just make sure that they're actually able to retain the information that we deliver. These are attitudinal questions that we ask them. The blue bars are InFOCUS 5 pre, so before InFOCUS 5, and the red is after, right after InFOCUS 5. The first group is making errors in medicine is inevitable. As you can see from this, you can view that question from 2 different perspectives. It may mean for certain medical students, and the way we interpreted this is that, yes, you should anticipate errors to happen as you go through this clinical rotations. So there is an inevitability of errors being made. But you can also view it from the standpoint like errors do happen, and that's the reason why we're doing all these preventive measures to make sure that they don't happen. So we prefer the former interpretation, that they do see that making errors is something that they should anticipate as they go through their clinical practice. The second is after an error occurs, an effective strategy is to work harder to be more careful. So this is one of the biggest drop from 82% to 61%. So in addition to themselves as a possible reason why an error is being committed, there are other errors that may be within the system's perspective. So now there's a firmer understanding that systems may play a role in the creation of an error or a near miss. And that's the reason why we were happy that from 82% before the course, it went down to 61%. The third, fourth, and fifth one are quite obvious. Competent physicians do not make medical errors that lead to patient harm. Reporting systems do little to reduce future errors. And the last one is most errors are due to things that physicians can't do anything about. We asked them again at the end of InFOCUS 7, which is highlighted in green. So at the end of the 3 weeks, so you can see that there is still persistence of the reduction, especially in the second bar. And I think Bridget, Dennis, and Shashi and I are really looking at this from an interpretation of they now fully understand that it's not just them that needs the change, but also there are other systems and other factors that may play a role, which has been evidenced by all of the process maps that they've done. So these are attitudinal questions regarding comfort. So the first one is, I feel comfortable reporting a medical error using the hospital reporting system. The second one is, I feel comfortable explaining to someone the hospital process in investigating a medical error. I feel comfortable creating a process map for a hospital process. And the last one is, I can list system causes of an error or a near miss. And you can see there's an improvement before and after InFOCUS 5. And if you look at retention, and this is same questions at the end, which is 9 months into their clerkship in InFOCUS 7, there is still retention. You can see from the green bars, and some of them actually are much higher, especially some of the questions that are more experiential, which they just went through. So in reflecting back, and as we continue this continuous process improvements, there are a lot of challenges that we've seen, and one of them is curricular time. Starting at 8:30 in the morning up to 5 p.m., just trying to put everything together into 3 individual weeks it's difficult with competing priorities, not only from perspectives of us designing the course, but also from the perspective of the medical students. And that's why you can see a big preponderance of clinical skills in the first part of InFOCUS 5 because of the need for the medical students, but also there's an increased part of career planning service at InFOCUS 7, in addition to short time because of the need for them to get prepared for 4th year and for residency application. So we're trying as much as possible to have that mixed bag, have a cohesive theme, and that is ensuring that everything that they do has something to do with patient safety and quality improvement. Content expertise, Mark is here, who's an expert in patient safety and QI, and we have Dennis as well. But like what we asked you at the very beginning, there's a lot of us who are not trained in patient safety and quality improvement. So I think finding content expertise, and hopefully with the maturation of InFOCUS 5, 6, and 7, with the regular educators that we do have, and hopefully that we'll have a cadre of educators who are comfortable with teaching this important topic. And again, this question of bolus and drips, and I feel that we are doing boluses at this point of 3 boluses during 3 individual weeks. And in between, they do their clerkships. And we've been challenged in trying to figure out how to provide the drip effect during this time. So they won't forget about InFOCUS 5 3 months in, and then especially forget about InFOCUS 6 months further out. So we're trying to figure out a way how to have a drip effect, but without disrupting their educational process within the clerkships. Because as you know, there are grades in the clerkships, and they really want to make sure that their clerkships are prioritized and they get the best grade possible. So we're trying as much as possible to figure out ways on how to have a drip in addition to the boluses that we do. The last slide is looking at lessons learned, and I think providing content relevance is always key. We feel that it was important for us to partner with system leaders like Mark in aligning QI projects with institutional priorities, so the students don't feel it's like busy work for them. We made sure that these are priorities within the departments, divisions, floors, units, and the institution that they really want to make sure that they want to improve, and having the medical students who work on that process. And what Dennis has mentioned, some of them actually have brought the same exact process maps that the medical students did to their meetings for their units and for their staff. It's also an important way that, when was the last time we had Mark teach in the medical school, showcasing the leaders that we do have, that there are other career paths that students may actually focus on, in addition to taking care of patients, that these are real career paths that our individual health system leaders have done. And again, tapping into content experts with field experience, and I specifically put in field experience and not just theoretical, because we do know for a fact that the medicals do respond to an experiential learning, somebody with the hands-on field experience to patient safety and QI. They liked stories. So when we had 1 year where we had all the CMOs from all our different hospitals in the health system come, they love hearing about the stories on how they dealt with, like Brian Radbill's famous for C. diff in Mount Sinai Hospital of Queens, and how he went through this whole process and trying to, as one of the top hospital that actually was able to bring down the incidence of C. diff infections in his hospital. It was fascinating for the medical students to learn about that, and their questions are very poignant and very direct to how, the process in which that happened. It's always a struggle to lessen the cognitive load. It's a lot of things to put in, and I think the bolus and drip phenomenon, or challenge would focus on that. So we try as much as possible to vary the instructional methods, so they are not always stuck in small group or in large group. And then again, we tried as much as possible to limit the duration of overall content delivery, so there will be an opportunity for the medical students to actually have an interactive portion to their learning. So I just want to acknowledge, just like what Shashi has mentioned, the entire curricular design team for InFOCUS 5, 6, and 7, all participating educators, and like what the slides mentioned, from nutritionists, respiratory therapists, from standardized patients, from social workers, it's a whole quality officers and health system leaders. There's a lot of participants in the course. Our leadership, as well as quality officers in our system, the Department of Medical Education, and also our medical students for being the initial group of medical students to have this. It's always fun. It's always challenging to teach this new course. It's frightening, honestly. It's a very apt description. Again, that's why providing relevance, that they, at the very least, they know something about patient safety and quality improvement. Hopefully, 5-10 years down the line, that they will remember something about patient safety and quality improvement, since their practice of medicine is going to be totally different than how we practice medicine nowadays. Thank you very much, and if you have any questions.